Hello, everybody. You guys may have heard of NBME 1, but how many of you guys have actually taken that exam? Well, I've gone through that exam, I've learned what I can from it, and based on my experience and understanding, I've created 200 questions that are completely original, which cover high-yield NBME topics. So many medical students are like, I finished the NBMEs, what now? Well, I'm completing a video series on all of the NBMEs, where I'm creating original questions that cover the topics that you will see when you finish those exams. But today I wanted to do something different. I wanted to start with NBME 1. So without further ado, here's everything you need to know based off of NBME 1. If you find it helpful, like and subscribe. Here we go. Question 1. A term male newborn becomes cyanotic and tachypnic within 2 hours of birth. The infant has a heart rate of 170, respiratory rate of 65, and oxygen saturation of 78% despite 100% oxygen. A single loud second heart sound. That's heard. That's our S2 sound. No murmurs are appreciated. Chest radiograph reveals egg on a string. What does that make us think of? This is transposition of great vessels. Which of the following interventions is needed? If you're studying for step 2, you probably know this is balloon, atrial septostomy. Now this is the explanation. Egg on a string, single loud S2, maternal diabetes. These are the pathognomonic words that will tie you into transposition of the great vessels. Here are the associations in the pathophysiology. But basically, a newborn can be pink and healthy at birth, and then they turn as blue as a blueberry within just a couple of hours. And this is due to a congenital heart defect. It's when the pulmonary and the systemic circuits are in parallel instead of series. In transposition of the great vessels, the aorta comes off of the right ventricle and the pulmonary artery comes off of the left ventricle. So blood from the body keeps going back to the body, and blood from the lungs goes back to the lungs. There's no mixing and there's no oxygen delivery. It kind of defeats the whole purpose of the heart and lungs, doesn't it? And at birth, the babies are kept alive by structures like the patent ductus arteriosus and the foramen ovale. And when those close, the mixing will stop and cyanosis becomes super dramatic. And so you'll see an S2 sound and then an egg on a string for the silhouette. This is a true shunt. And the fix is you have to get those two circulations talking to each other again. And that's why you need the balloon atrial septostomy. You open up the atrial septum so that the blood can mix. All right, that's the egg on the string. That's what people are referring to right there. So those are the key features. Now let's talk about these answer choices. First of all, endomethacin, that would close the PDA, and that would worsen the cyanosis. So you can't give them endomethacin. PDA and ligations are NSAIDs. You're trying to keep those things open, right? Oxygen supplementation, that's ineffective in a right to left shunt. PDA ligation, that removes one of the few mixing routes that you have, and that would worsen the hypoxia. And vagal stimulation, that's for supraventricular tachycardia, and it's unrelated to the structural cyanotic heart disease here. All right, now let's do this next question. Zooming on to 2. Now, I don't actually have a question for this one, but I just wanted to flag that elder abuse is a real thing. Somebody is in their advanced years, 70 plus, and they can't go get groceries and nobody in the family is helping them, then this is elder abuse. You should contact the authorities. All right, that's a question that you see sometimes on these NBMEs. And next is question 3. A 54-year-old woman collapses at the airport shortly after a 10-hour flight from Europe. Bystanders report she complained of a sudden shortness of breath in the breast and chest discomfort moments before losing consciousness. She has been undergoing chemotherapy and pancreatic cancer. She has been undergoing chemotherapy for pancreatic cancer and reports no recent trauma. Despite immediate resuscitation efforts, she is pronounced dead in the emergency department. Which of the following is going to be found on the autopsy? So this is a DVT, and it's deep vein thrombosis is going to be the answer. Here are the buzzwords, associations, and pathophysiology. Basically, she has a malignancy, it's hypercoagulability, and also prolonged immobility from the air travel. And those are classic risk factors for DVT. And a large thrombus is likely embolized in the pulmonary artery, and that causes a sudden cardiovascular collapse and death. Autopsy would show thrombus in the deep veins, usually the femoral or the iliac. There's the risk factor, Virchow's triad, stasis, endothelial injury, and hypercoagulability. So the thrombus forms in the deep veins of the leg to the pelvis, and the embolus goes through the right heart to the pulmonary artery obstruction, and you get pulseless electrical activity or cardiovascular collapse. Now let's go through these answers. Coronary artery plaque rupture. That would cause an acute myocardial infarction and would expect ECG changes, not a massive pulmonary embolism. Aortic dissection. That's a severe tearing chest pain, unequal pulses, and is not linked to prolonged travel. Left atrial mix. That can cause embolic events, but it's super rare, and it would not match just these risk factors that are given. And then E, ruptured berry aneurysm, that's a sudden headache, subarachnoid hemorrhage, and neuro findings, not chest symptoms. So I've taken some notes beforehand, and here I've written postpartum OCP, adenocarcinoma, factor 5 leading. These are all hypercoagulability factors. So a woman steps off of a long flight, and then she takes a few steps and dies. She collapses. It's a perfect storm of Virchow's triad. It's a stasis from sitting for a long time, hypercoagulability from her pancreatic cancer, and also endothelial triggers. So the clot is deep in the leg veins, femoral, iliac, and maybe the popliteal. It breaks loose, and then it sails through the right heart, and then it wedges into the main pulmonary artery, and then the blood stops, and then the heart keeps its rhythm. There's a pulseless electrical activity, but there's no blood that's moving. And so you'll find deep vein thrombosis in the leg. That's the source of the killer embolus. Moving on to question 4. A 32-year-old woman presents with a 4-month history of burning chest discomfort that worsens after eating when lying down. Okay, we're talking about GERD, sour taste. What's the abnormality in this patient? It's probably going to be lower esophageal sphincter relaxation, and it indeed is Transient to inappropriate relaxation of the lower esophageal sphincter. So this is GERD, and risk factors are obesity and late night meals. The pathogenesis is often in transient inappropriate relaxation of LES. That's the acid reflux that you'll see. The buzzwords are worse after lying down, distal esophageal erythema erosions, hiatal hernia, Barrett's esophagus. That's the metaplasia. I'll have another question about that soon. Now let's look at the answer choices and kind of eliminate them. Diffuse spasm, that causes dysphagia and chest pain, not erosive esophagitis. So it's not diffuse spasm. Because yeah, you couldn't eat and it would hurt, but different story. Failure to relax after swallowing would be achalasia, and that would have progressive dysphagia as well. H. pylori would cause peptic ulcer disease. It's not primarily a distal esophagus disease. And hypersensitivity, that's related to the functional GI disorders, not the erosions. So if you've ever had like a heartburn after a big late night meal, it's LES physiology. So normally your lower esophageal sphincter keeps the stomach acid where it belongs, but sometimes it'll relax when it shouldn't, especially in people who are overweight and pregnant and eating trigger foods. And then the acid, what happens is it splashes into the esophagus and it burns that lining and it causes the retrosternal burn. And over time, you can start to get erythema, erosions, and Barrett's esophagus. So that's Barrett's metaplasia on endoscopy. So it's transient, inappropriate relaxation of the LES. It should be closed. It's not a failure to relax. That would be achalasia. And it's not even an infection. Like H. pylori would be like a stomach bug. It's also not a nerve sensitivity. There's actual injury here. And the bottom line, this is LES relaxation. And then first line treatment for GERD is lifestyle modification and a trial of proton pump inhibitor therapy. So usually weight loss is helpful. Avoid meals 2 to 3 hours before lying down, elevate the head, things like that. Also, you can give an 8-week course of a once daily PPI for the first meal of the day. And PPIs, you have like omeprazole, the prazole, right? And those are preferred over H2 receptor antagonists for the initial symptom control. And then you slowly move that to the lowest effective dose. And that's kind of how you manage chronic GERD. And there's going to be another question that we ask about GERD as well. So get ready. Boom, I've taken notes on this one. This is Barrett's, and then you have dysplasia and adenocarcinoma. So a 59-year-old man has a 10-year history of nighttime heartburn and regurgitation, now reports 3 months of difficulty swallowing solid foods and an unintended 6-pound weight loss. He's got a 30-year pack history in central obesity. He takes over-the-counter antacids intermittently. Vital signs are normal. Endoscopy shows ulcerated exophytic mass of the gastroesophageal junction with the surrounding tissues of a salmon-colored mucosa extending proximally. Which of the following histological molecular findings is most consistent with the pathogenesis of this patient's disease? Well, we got some good answers here, but the correct one is columnar epithelium with goblet cells and mutations involving TP53. Now, some of you might have chosen keratin pearls with malignant nests in the mid-esophagus. So that's squamous cell carcinoma. That's the keratin pearls. And that would fit squamous cell carcinoma in the upper and mid-esophagus. That's linked to alcohol and tobacco, not the distal with the Barrett's changes. So distal is the Barrett's, then upper is going to be alcohol, tobacco-related squamous cell carcinoma. So it's not the correct answer. Next is non-keratinized squamous epithelium with eosinophilic microabscesses. So that's the food impaction history. You'd also see like atopy there. It's a genetic predisposition for developing allergies. That's just not really this question stem. Also, why would you have weight loss, which this person has if that were the case? So no, that's not the right answer. Dense submucosal fibrosis. So that would be like a peptic stricture that causes dysphagia from chronic inflammation leading to fibrosis, no mass or weight loss. And it would not be tied to any malignant transformation. So that's not the right answer. And then Candida. That is infectious esophagitis. It occurs in immunosuppressed patients, and you'd have white plaques, not malignant mass or Barrett's mucosa. So it's chronic heartburn that just rewrites your esophagus. You have years of acid reflux. The distal esophagus wipes out its fragile squamous lining for the tough intestinal type columnar cells, and that's Barrett's. It's adaptive, but it opens the door to dysplasia down the line, and then adenocarcinoma. So the risk factors are obesity, smoking, hiatal hernia, and then the solid food dysphagia and weight loss, and you should already be thinking of this diagnosis. You'd see salmon-colored tongues that are creeping out of the GE junction. And you have columnar cells with goblets, and as dysplasia advances, you get mutations of TP53, and that means it's malignant. So it's GERD's, Barrett's, dysplasia, adenocarcinoma in the distal esophagus. All right, on to the next one. So I've taken notes on this one as well. A 27-year-old man presents with a 6-month history of intermittent abdominal pain, chronic diarrhea, and some weight loss. He reports occasional blood and stool. Exam shows mild pallor and tender right lower quadrant. Studies reveal hemoglobin level of 10, MCV of 114, and decreased serum B12. Yeah. Okay. Colonoscopy shows areas of normal mucosa. Which of the following is most likely the explanation for the vitamin deficiency? The answer is the inability of cobalamin intrinsic factor complex to be absorbed. All right. There are the explanations. Crohn's affects the terminal ileum where vitamin B12 intrinsic factor is absorbed. So you get malabsorption and megaloblastic anemia. Different than pernicious, which is autoimmune destruction of the parietal cells. So it's not A. And the reason why it's not A is because pernicious anemia is parietal cell destruction, and that's B12 deficiency from a lack of the intrinsic factor, not ileal malabsorption. It's not B, that's the failure to bind the intrinsic factor, and that's a rare congenital IF deficiency, intrinsic factor. It's not linked to Crohn's. It's not loss of gastric acid, that's achlorhydria, which can impair iron absorption, but it's not B12 mechanism here. So vitamin B12 is cobalamin, and it acts as a cofactor for different enzymes, methionine synthase, and also methylmalonyl-CoA mutase. So it's super important in DA synthesis and red blood cell formation. And it's not your pancreatic enzyme deficiency that can cause B12 malabsorption from the impaired R-binding cleavage, but that presents with steatorrhea and fat-soluble vitamin deficiencies. Let's look at the buzzwords. B12 absorption in the terminal ileum. Crohn's disease often involves the terminal ileum, so it's Crohn's, and you have malabsorption of B12 bile salts. You see skip lesions from mouth to anus, cobblestone mucosa, string sign on barium, and you get kidney stones because of bile salt loss and the fat binds to the calcium, and you get free oxalate absorbed, gallstones, cholesterol supersaturation, and non-caseating granulomas. You can also have that B12 deficiency, megaloblastic anemia, and neurological defects. All right, moving on to the next question. We have a 68-year-old man presenting with evaluation from exertional dyspnea that has been progressively worsening for 1 year. He's also had a 20-year history of untreated hypertension. Blood pressure is 174/96. Cardiac exam shows low-pitched sound just before the S1. Best heard of the apex and the bell of the stethoscope, while the patient is lateral decubitus position. Which of the following is best explains these findings? All right, so he's got an S4 sound, late diastolic, 10C. Apex, that's what you hear when you listen. And you've got some stiff presentation in your ventricle. And that S4 sound tells you it's hypertension. So the answer is atrial contraction against the stiff left ventricle. So that's just the S4 sound. That's all you need to know. Okay, next question we have 43-year-old man, acute onset severe pain, redness, swelling of his right toe. This is gout. I'm just going to keep going. Which enzyme is most likely affected in the gout one? And this one is PRPP. There's the explanation. PRPP synthase, rate limiting step, normally inhibited, but you have a loss of the feedback, and so you have purine overproduction, uric acid excess, and gout. Adenosine deaminase, that's SCID, so that's not the right answer. Dihydrofolate reductase, that's targeted by methotrexate. It's not linked to gout. G6PD is deficiency with hemolytic anemia and oxidative stress. HGPRT is deficiency of Lesch-Nyhan syndrome. And there the problem is increased PRPP synthase activity. There are two different purine pathway problems that look very similar in terms of the downstream uric acid, but they also differ in where they occur. So PRPP, that's this answer. It's a key substrate for both de novo, and HGPRT is salvage enzyme that converts hypoxanthine into IMP and converts guanine into GMP. It uses PRPP as a substrate. And so HGPRT, that's Lesch-Nyhan syndrome, it's a loss of the salvage pathway. So hypoxanthine and guanine are not recycled. PRPP accumulates because it's not consumed, and de novo purine synthesis is upregulated due to that buildup. So it stimulates the rate-limiting enzyme of purine synthase, and you get lack of feedback inhibition. But in PRPP synthetase activity, the PRPP synthetase, ribose 5-phosphate, it uses ATP, and you have increased enzyme activity over production, and that drives de novo purine synthesis excessively. And so the salvage pathway is just overwhelmed, and still more purines, more uric acid. So you see gout, hyperuricemia in adults, kind of similar mechanisms, just that with this one, you have an overactivity of PRPP, and in HGPRT, you have Lesch-Nyhan's, which is salvage pathway enzyme loss. The difference there is that in HGPRT Lesch-Nyhan, you have severe self-mutilation and other neuro problems. And the onset is infancy typically, and then this one is typically a little bit later unless it's very severe. You treat them both with allopurinol and Febuxost. So HGPRT, no salvage, neuro and gut problems. Then PRPP is too much substrate and gout only. Okay, so that's the difference between them. Now let's go to the next question. 35-year-old man has progressive difficulty relaxing his grip and handshakes, mild facial weakness, early onset cataracts. He says his 60-year-old mother had similar symptoms. Genetic testing reveals unstable trinucleotide. This is anticipation. Now they could have made this much harder, but I'm going to zoom in here. Cataracts, toupee, gonadal atrophy, myotonic, Huntington's causes low acetylcholine and GABA. That's Huntington's. And then fragile, CGG, chin, and then giant gonads. So that's how you remember them. CTG is cataracts, toupee, gonadal atrophy. CAG, caudate loses acetylcholine and GABA. Here are the buzzwords associated with this. But basically, each successive generation has an earlier disease onset. It just keeps slipping. You get more and more of those trinucleotide repeats. So here, the patient's mom got her symptoms in the 40s, but he's already showing weakness in his 30s. Cataracts, myotonic dystrophy. Okay, next question. This is question 10. We're flying through. This is about C-peptide. A 29-year-old nurse is brought to the emergency department after being found confused and diaphoretic. Finger glucose is 35, but then her serum C-peptide is undetectable. What does that mean? She's doing surreptitious insulin administration. So anytime you have exogenous insulin, then you have high insulin and low C-peptide, because if you make it endogenously, then you're going to generate C-peptide. And since she has low glucose, that means she's giving it to herself, which is really sad. Autoimmune destruction of the pancreatic B cells, this type 1 diabetes. Islet cell tumor, that's an insulinoma. It's high insulin and high C-peptide would be seen. Sulfonylurea ingestion, that stimulates endogenous stuff, so it would cause high C-peptide. Even though she's giving it to herself, sulfonylurea ingestion, still, it's endogenous. This is just exogenous, surreptitious use. Hepatic failure is hypoglycemia from impaired glucose production. Okay, moving on to the next question. We are flying. If this is helpful, then like and subscribe. A molecular biologist is designing a probe to detect a specific bacteria DNA sequence. The DNA sequence is first denatured and then cooled, which describes the hybridization under these conditions. It's a mismatched DNA hybridization is prevented. This is kind of a specific interaction that you're going to do where there's high stringency that prevents mismatched hybridization. So it's useful for detecting exact sequence matches in diagnostics. Now, A, considerable base matching is permitted. That would be low stringency, not high. B, CG pairing is unaffected. C, GT is a mismatch and not promoted under high stringency. And E describes the non-specific binding and low stringency. So basically, when DNA is heated, the strands are going to separate. So you cool it down and then the pair can join back up again. But whether they match perfectly depends on the conditions, right? So in high stringency conditions, you have high temperature, low salt, and only the perfect complementary strands are going to reanneal. Even one mismatch would prevent the binding. And that's how the labs get super high specificity for tests like Southern blots or microarrays. It prevents the false positives. So that's what they're doing here. Next one, we have a 27-year-old woman in second pregnancy, presents with a routine ultrasound at 26 weeks gestation. She reports no complications so far, but fetal growth has been slowed compared to previous visits. Ultrasonography reveals markedly reduced amniotic fluid and absent fetal bladder filling and bilateral absence of visible kidneys. Okay, this is probably Potter's sequence, and you're going to have an abnormal renal activity here. It's not cardiovascular that can cause growth restrictions, but not directly oligohydramnios. And oligohydramnios, by the way, is when you have too little amniotic fluid. And amniotic fluid is the fluid that surrounds the baby while they're in your body before birth. And the baby needs amniotic fluid to grow. And that watery fluid is inside of the amniotic sac or the membrane. It's not the central nervous system. That's a neural tube defect that can cause polyhydramnios that's impaired swallowing. It's not gastrointestinal because the esophagus and the duodenal atresia causes polyhydramnios, not oligohydramnios. And it's not hepatic because that would have no direct effect on the amniotic fluid volume. So about 20 weeks of pregnancy, most of the amniotic fluid is actually going to come from the fetal urine. And if the kidneys don't form, or if there's a blockage, then the baby can't make enough fluid, and that's oligohydramnios. And too little fluid causes compression of the womb, right? You don't have enough buffering there, and that leads to a flattened face limb deformities and also underdeveloped lungs. That's Potter's sequence. So in ultrasound, you see almost no fluid pockets, maybe no visible kidneys, or there's no bladder filling. So in this case, the malfunction is the renal system. So no pee is no pool, and that means you get smashed and you have abnormal facies and dysgenesis, flattened facies, limb deformities. So you need that pee if you're a baby at week 20. Man, how does he do it? I'm just kidding. All right, just a little ethics thing here. Always ask open-ended questions. Try to figure out the whole patient's condition so that you can make sure that they have autonomy over the decisions. That's my ethics tip for the day. So here's this next question on diphenhydramine. I've done this beforehand. A 76-year-old man is brought to the emergency department by his daughter due to new onset confusion and difficulty urinating. He's got constipation, dry mouth, and he had allergies, but he took diphenhydramine probably, and he's Beer's criteria, so 76-year-old, and physical exam shows distended bladder and dry mucous membranes. Which medication did he take? Diphenhydramine is the answer, because this is a first-gen antihistamine. It blocks muscarinic receptors and it causes anticholinergic side effects. You know those like hot as a hare, dry, red, blind, mad as a hatter, all that stuff. Diphenhydramine overdose. That's like delirium is caused in this condition. Loratadine is not the correct answer. That's a second-gen antihistamine, has minimal CNS anticholinergic effects. Docusate sodium, that's a stool softener, so no. Pseudoephedrine is an alpha agonist, nasal decongestant, and it causes urinary retention, but it's less likely to cause confusion. Ranitidine is an H2 blocker. It has minimal anticholinergic effects. And anticholinergic effects, those are the ones that inhibit the physiological action of acetylcholine, especially as a neurotransmitter. Okay, next question. Here we have a 34-year-old woman presenting with evaluation of a thyroid nodule. She reports occasional palpitations and denies weight loss. Which of the following is the most likely diagnosis? Thyroid tests show slightly suppressed TSH and normal T4. A radioactive iodine uptake scan reveals intense uptake confined to the nodule. Okay, so hot nodule is what's going on. Fine needle aspiration shows well-circumscribed lesion. So this is going to be a follicular adenoma. It's hot nodule, and benign histology means that it's not papillary carcinoma, because that would be a cold nodule, and orphan Annie nuclei would be seen. Medullary carcinoma is not correct either. That's calcitonin-producing C cells, she cells by the seashore. Medullary is calcitonin-producing C cells, and also amyloid stroma. Granulomatous thyroiditis. That's painful thyroid and low uptake. That's a painful thyroid with low uptake due to follicular destruction. And anaplastic carcinoma is aggressive elderly patients and cold on scan. So cold. This one's hot, intense uptake. It is follicular adenoma because of the hot nodule and benign stuff. Not medullary because that's calcitonin producing C cells and amyloid, and it'd be cold. So cold hurts. So it has to be B. And hot nodules are almost always benign, and it's most commonly due to follicular adenoma. Encapsulated tumors that produce thyroid hormone on their own without waiting for the TSH. Next, a 40-year-old man with advanced HIV presents with a 3-week history of headaches. He's got difficulty speaking, weakness in his leg, and he has not been taking antiviral medications. He's got a CD4 count of 70 MRI shows multiple ring-enhancing lesions. It's toxo, easy peasy lemon squeezy. Toxo is leading cause of multiple ring-enhancing lesions in AIDS patients with a CD less than 100. Reactivation is more common than primary infection. It's not Cryptococcus neoformans. That causes meningitis, not ring lesions. It's not the JC virus. That's progressive multifocal leukoencephalopathy, non-enhancing and white matter lesions. Listeria causes meningitis in immunocompromised, not multiple lesions. And Aspergillus fumigatus can cause brain abscesses, but usually it's solitary with a vascular inclusion. So here there's like the protozoan toxo that hides out in the tissue cyst after a silent primary infection. And then when you're immune compromised, then it wakes up and it causes lesions in the brain. All right, next question. 62-year-old man undergoes colonoscopy for evaluation for intermittent hematochezia. The endoscopist finds 6-centimeter sessile lesion, and it's got a velvety surface. V for velvety means V villus adenomas, and that's going to be adenocarcinoma. It's dangerous if it's V velvety. It's the highest malignant potential of any adenomatous polyps, and it increases if it's sessile. That's like fixed in one place, immobile, and villus. So if it's sticking there and it's villus, then you're in trouble. It means like stuck there, covered with villi. Large bowel obstruction that's possible with a left-sided carcinoma, but the cancer itself is the primary risk here. Ischemic colitis, that's unrelated to adenomas. Carcinoid tumor is neuroendocrine origin, and sigmoid volvulus is the twisting of the bowel. So if you see soft, velvety sessile with broad base and finger-like projections, then it's got a big risk to transfer into adenocarcinoma through the adenocarcinoma sequence, APC, and then CRAS, and then P53 loss. So the larger the lesion, over 4 centimeters, the more villous the architecture. And so there's a higher malignant potential. All right, next question, the Starling mechanisms. A researcher applies a pressure cuff around the thigh of a volunteer and inflates it to a level that occludes venous return while allowing arterial inflow. After 10 minutes, the subject's lower leg appears swollen. Which of the following is most likely the cause of the edema? It's increased mean capillary hydrostatic pressure. All right, so here is the equation that's relevant. But you should think of the capillary hydrostatic pressure as water pressure in a hose. Venous occlusion is like you kink it at the end and pressure will back up and water will leak out. So you have fluid in the tissue. Well, that's all well and good, but why not the others? Well, interstitial hydrostatic pressure would favor filtration, but a tourniquet does not meaningfully drop the PI. That's the intermediate. So the immediate change is going to be increase in the venous capillary pressure upstream. It's not plasma oncotic pressure because that would pull the fluid into the capillaries and that opposes edema. It's not D or E because D would be increased capillary filtration coefficient. That would mean increased permeability. That's like histamine and inflammation. A pure venous occlusion does not change the membrane permeability, just the pressure. And it's not E because the reflection coefficient. The tighter barrier to proteins, the less protein leak. All right, for this next one, I just wanted to explain the mechanism of fludrocortisone. It's a mineralocorticoid activity. It acts like aldosterone and it increases sodium reabsorption, potassium secretion, and hydronium secretion in the urine, causing metabolic alkalosis. The effect on the renin, increased BP, increased extracellular volume, negative feedback, causing lower renin from the JG cell. And the last one, question 20, the topic that you need to know is if you have a young sexually active woman with fever and purulent vaginal discharge, that's PID. And so you'll be expecting a tender mass in the right lower quadrant, and the fallopian tube is the structure with ectopic pregnancies, and that's because you have a tubo-ovarian abscess. So PID causes an increased likelihood of infertility in ectopic pregnancy. So you see young woman, fever, abdominal pain, purulent discharge, think PID, fallopian tube. And PID is caused by Neisseria gonorrhea or chlamydia. And this has been the first 20 questions. If you like this series, then let me know and I'll keep doing the NBMEs, hoping to get up to 750 subscribers. See you guys in the next one.